All right, thank you, Dr. Zhang, for your kind introduction, and good afternoon, ladies and gentlemen. So what I'm trying to do in the next 15 minutes or so is try to zoom in a little bit for one of the effective arms in the combat of the antimicrobial resistance, and that is the antibiotic stewardship program. And to start with, I would like to show you the history of the development of the antibiotic stewardship program in Hong Kong. And before year 2005, ASP is only available in a limited number of centers. And in fact, one of our moderators, Dr. Sito, is the pioneer in the development of ASP in Hong Kong. And it's not until year 2005 we have a centralized program on the implementation of ASP in all the acute hospitals in Hong Kong. So in the first few years, things went smoothly. And it's at the year 2009 that we decided to let the people to do their own job at the hospital level. But then with all the challenges that I'm going to show you in the next few slides, we decided to reform the work group on the ASP under the central governance so as to help our colleagues to better perform the ASP in the public hospitals. And of course, with the government launch of the strategic plan of the AMR in Hong Kong 2 years ago, we are also taking our part in the combat of AMR. And therefore, we try to reform and review our system again so as to make sure that our job is done properly. So what are we going to do now in terms of the ASP in the public hospitals? Before we go into the service model that we are adopting right now, I will try to show you the rationale behind our work. Now, think about the antibiotic prescribers. So what are the time points for us to add upon in terms of the guidance of the antibiotic usage? Of course, when the people start to use the antibiotics, the first thing to think about is whether the prescription is appropriate, whether the patient needs the antibiotic or not, and if they need it, what is the appropriate choice, all right? And of course, during the course of the patient management, we'll think about whether we can streamline the antibiotic therapy in terms of the choice, whether it could be lower to a lower spectrum, and also at that time point, whether we can switch the intravenous route of the antibiotic administration to the oral route so as to facilitate the patient's discharge and subsequent management. And of course, during the subsequent days, another question that we need to answer is whether we can stop the antibiotics, which is based on the culture result, microbiological investigations, and also the patient's clinical condition. So in order to help them to make the right choice at the appropriate time point of the course of the patient's management, here are the things that we are trying to do in our ASP. First, at the start, we have the guidelines and also the education training for our staff in terms of appropriate choice of antibiotics. And also, we emphasize the use of appropriate microbiological workup to help for the subsequent guidance in terms of the lowering of the antibiotics of choice. And secondly, during the course of management, once the culture result or other microbiological investigation results are available, we try to lower down the spectrum of antibiotic usage as far as possible. And before we can persuade our prescriber to stop the antibiotics early, we need to show some objective evidence so that they can actually feel comfortable to stop the antibiotics, especially when we advise them to stop the antibiotic at an earlier time. So here comes the use of the biomarkers like the procalcitonin, which were actually introduced this year in our hospital service. And of course, during the course of the patient's management, we need to have an ongoing clinical assessment so as to make sure that all the things are done properly. Okay? Our patients are actually appropriately treated despite our adjustment of the antibiotics usage. So based on this framework, this is the current service model of the antibiotic stewardship program in the public hospitals in Hong Kong. And our clinicians from the 4 key departments, that is the medicine, surgery, orthopedics, and ICU, are our target to intervene. So the key points here are we empower them on the few parameters. One is to order the appropriate microbiological workup when you consider the use of antibiotic. Second, when you prescribe antibiotics, you need to follow our local guidelines on the antibiotic usage in terms of choice, route, and so on. And as far as the laboratory test was concerned, when it's done, the result will be available for a couple of days' time. And it's at actually this time point that the antibiotic stewardship team will intervene in terms of whether the drug is actually appropriate choice for the patient's particular condition. And if not, we will provide what we call as a concurrent feedback to our clinicians so as to adjust the appropriate choice of antibiotics accordingly. And During the course of the patient's management, of course, we will review the patient's condition and also to stop the antibiotic at the appropriate time point. And based on these audits and also the concurrent feedback, we will compile results on a regular basis to the front-end clinicians as well as to the management, so that they can, based on these kind of data, to drive on the improvement program in terms of the antibiotics usage. Now, as for the targeted antimicrobial therapy that is chosen for the interventions by the concurrent feedback, currently we focus on the therapy drugs, namely the imipenem, meropenem, as well as the piperacillin tazobactam. All these are broad-spectrum antibiotics with extended gram-negative activities. And in fact, it constitutes about 70% of the so-called big gun usage in our public hospitals. And so we use this as a surrogate marker for our interventions. And at the same time, the ASP team will try to look into all prescriptions on the last resort antibiotics. Say, for example, the colistin for the resistant gram-negative, the use of the daptomycin for the resistant gram-positive, and so on, so as to make sure every case was having the appropriate prescriptions. And also, the work group on the antibiotic stewardship program will give recommendations on the indications of all those new and reserved antimicrobials for the multi-drug resistant organisms. And on top of that, depending on the local situations and also the provision of manpower, each hospital can also pick additional choices of antibiotics for the auditing and also the interventions. Now, as I told you, we will compile the report on the usage of antibiotic on a regular basis. Basically, we will do it on a quarterly basis, and we will have a comprehensive list of the antibiotics in terms of the DDD data for our end users as well as the schedule for reference. We try to group them into few groups. Number one, the first group will be the broad-spectrum antimicrobial with extended gram-negative against the Pseudomonas and also the ESBL producers. And the group 2 antibiotics is those alternatives to the group 1 antibiotics, so that we try to monitor for the possible squeeze the balloon effect, because people, when they don't use one antibiotic, they may choose to use another, right? And the group 3 antibiotics is those antibiotics that have extended activity against a resistant gram-positive. And at the same time, we also monitor the use of the last resort antibiotics in terms of the DDD. So, for example, the linezolid, colistin, tigecycline, daptomycin, and also the new antibiotics that are introduced to the public hospital system, like the ertapenem and ceftaroline. So we will compile the data from hospital, department, and the department level, so that each unit can have their own sort of a set of data to review on the secular trend on the antibiotic usage, and also to compare with the hospitals and units of their similar size, so as to understand how they're performing. So here are the outcome markers that we try to measure in terms of the success of the antibiotic stewardship program and also the usage behavior of our frontline clinicians. Number one, of course, is the volume of the antibiotic usage in terms of the DDD. And second, we try to monitor the percentage of appropriate use of the empirical antibiotics for our clinicians. And for those cases that we give interventions in terms of the concurrent feedback, we also will look at the percentage of the compliance to the concurrent feedback. And in this model, we actually put a lot of emphasis on the engagement of the frontline clinicians. And here are the things that we want to drive at, namely the appropriate clinical specimen collection for the microbiological investigations before starting the treatment as far as possible. And also, number two, the choice and dose according to the local guidelines. We have impact guidelines in this locality, and which is actually a joint effort for the academia and the local experts. So if you're interested, you can actually download the app to have a look of it. And of course, when we use antibiotic, we try to streamline it in terms of the step-down therapy. And also, as far as possible, we try to switch the IV route of antibiotic to the oral route. That will help the management of the patient. And of course, now, the last point is also very important. Nowadays, we try to limit the whole duration of antibiotic. We try to give adequate antibiotics on one hand, and we try to avoid unnecessary use of antibiotic in terms of a prolonged duration. So this is what we are doing right now. And what are the gaps and challenges that we are really facing? Now, as the AST member, they often face with increased diversity, complexity, and also volume of workload. And as such, the growth of the workforce is often not matched with the increased service demand. And therefore, the resource allocated to the implementation of ASP is often limited. Bearing in mind that these people are often wearing different hats. Say, for example, I'm an IT physician, I need to take care of the clinical management of patients. For microbiologists, they need to take care of the infection control and also the laboratory stuff. So when they have actually different types of competing interests on the different job natures, the time allocated to the ASP could be actually limited. Now, as for our budget holder, or our executive, they also have their own problem, right? In Hong Kong, we are facing up with a shortage of the manpowers in terms of doctor, so they may not be able to allocate the manpower for us for the implementation of ASP. And also within the healthcare system, we have a lot of other competing interests, so they have to make their own decision in terms of how much we can invest on the antibiotic stewardship program. And one point that I've often told by the executive was the effect of ASP was not directly tangible to them. Think about this, despite the implementation of ASP for the past some 13 years or so, the overall volume of antibiotic usage in this locality is still rising in the public hospitals. And on the other hand, we also face up with the emergence of the multi-drug resistant organisms in these localities. So what's ASP doing any good for us? So that's often the questions that they try to pose to us. But then we all know that ASP is only one of the effector arm in the comeback of the AMR. When we try to look at it alone, the efficacy may not be easily measured. So that's the problem. And as for the front-end conditions, they are now facing with aging populations, and also they have a multiple comorbid and chronic illnesses that bring them to the hospitals very often. And also we have an expanded population of immunocompromised patients. Say, for example, transplant recipients, those people who have immunological conditions receiving local immunotherapy like the biologics, that makes the development of infections, or also the diversity of infections being more complex. And in this locality, we are also witnessing a prevalence of the MDRO on the rise. Say, for example, the MRSA is actually quite endemic in this locality. In the past 10 years or so, we also witnessed the development of the carbapenem-resistant Acinetobacter in this locality. So for the front-end clinician, they have a pressing need in terms of the use of the broad-spectrum antimicrobial for the treatment of their patients, may it be on an empirical basis or also as a non-pathogen therapy. So what is the impact to us? Number one, the volume of the cases that they are using the broad-spectrum antimicrobial is on the rise. And number two, somehow the front-end clinician may perceive the ASP team as a kind of barricade for us to choose the antibiotic for the treatment of the patients. So we need to be very careful in terms of building up a relationship with our front-end clinicians on the antibiotic stewardship program. So all these factors will affect the sustainability of the ASP. So we have all these challenges and also the service gaps that we are facing with day in and day out. So is there any other opportunity to help us to perform ASP better? And perhaps one of the things that we can try to look into is the use of the information technology. And in fact, in Hong Kong, for our international guests, we have what we call as a clinical management system that we are using in the local hospitals and clinics in the public sector. And this is actually an electronic platform which gathers all the patient's information from their demographics, previous hospital discharge record, laboratory results, and radiological results, and so on. So there's a one-stop for us to manage the patients based on all these informations. And we have actually introduced the inpatient medication order entry system in the past few years to the public hospitals in Hong Kong. And this electronic platform will help us to prescribe the drug in a paperless way. So that actually did open up another dimension for us for the ASP interventions. And this IPMOE, the inpatient medication order entry system, was introduced in the Princess Margaret Hospital as a pilot in year 2013. And by now, most of the acute hospitals were having it in place. So what can we do with this inpatient medication order entry system? Just to show you some examples here. Now, basically, we can develop some standard regimen and also the drug set for the common conditions that clinicians are facing with. Say, for example, community-acquired pneumonia, we can provide a set of the antibiotics for them to prescribe. Okay, and also the regimen will be standardized, and we can actually have a better sort of a use of the antibiotic in terms of the Western lab. And number two, as I've mentioned earlier on, we try to limit the duration of the antibiotic prescription as far as possible. And in fact, in this system, we can actually have a stop order reminders for our clinicians, so that when they actually key in the proposed duration of antibiotic, towards the end of the proposed duration, a reminder flag will come up in the system, so as to ask them to review the indication of antibiotics and stop the antibiotic if it is actually appropriate to do so. So what are the other future development based on this inpatient medication order entry system? In fact, one of the things that we are now working on is to provide a standard list of indications for the target antimicrobial for clinicians to take reference to. Imagine when the prescriber prescribes the antibiotics through this electronic platform, a pop-up window will appear, and with a list of indications of that antibiotic that they can actually pick to choose. Okay? On one hand, that will guide them to the indications of antibiotics. On the other hand, this data can be used subsequently for the analysis in terms of the indications and the choice of the antibiotics. And number two, we try to link this IPMOE to the antibiotic prescription history of the patient. Of course, when they are exposed to some of the antibiotics in the, say, past few months or past few weeks, that will actually affect our subsequent choice of the antibiotic, because the patient, if they are having a new type of infections now and have a prior use of some form of antibiotic, we know that there may be a chance that the past history of antibiotics may actually influence our current choice, because the old drugs may have already been resistant. Right? And the few things that actually we are still working on is to linkage of this order system to the local guidelines, and also the calculator for the appropriate dosage for our patients. That will actually be used to link up with the renal functions and also liver functions of patients, so that dosage adjustment can be actually done on the spot right away. And in the long run, our goal is actually the development of a decision support system for the antibiotic prescribing. Right? We have all those good data within the system. Just as I've mentioned, the previous microbiological workup result, the radiology data, okay, the patient's past history, okay, and also the prior antibiotic exposure. All this actually can help for the clinician to decide whether the choice of antibiotics is appropriate, and also when to use a more broad-spectrum antibiotic for the treatment of the patient. So this is what I'm going to say today. Thank you for your attention.